Okay, so I'm Karen Jewell. I'm from Cardiff. I don't know whether any of you have read some of the stuff that we've been doing in Cardiff, mainly in relation to working with Slimming World, and that's the stuff that you may have heard of. At the moment, I work 4 days a week as a consultant midwife, working mainly with public health. Can you hear now? Yeah. So I work 4 days a week as a consultant midwife in public health in Cardiff, and I work 1 day a week with Cardiff University on a study called the HELP study. Has anybody heard of the HELP study? Yes, a few nods? Right. Okay, so what I'm hoping to do today is to talk about obesity and pregnancy, then talk about the pilot study that we had in Cardiff a couple of years ago now that led on to the major piece of research that was funded by the JFHC, and it's £1 million piece of research, so it's quite a big piece of research that's going on for 4 years. So I'll tell you a little bit about that, okay? And we're going to take questions at the end? Yep, brilliant. Okay, so what is obesity? In the UK, we measure obesity, and I'm sure Tam went through this morning, by BMI. BMI is categorised, between 25 and 30 is categorised as overweight, over 30 is categorised as obese, and 40 or more is categorised as morbidly obese. It's the women that have got BMIs of 30 or more in pregnancy that are the ones that we should be looking at. Now, for the midwives in the audience, you know that if you look at NICE guidance, we're looking at 35 and above being the point that we start looking at where people are going to be giving birth and saying that's when the problems occur during pregnancy. But actually, the 30 to 35 women are the ones that we really need to start looking at, and I'll explain why in a minute. This is called the fat map. You can see by the fact that there's a little red sore thumb sticking out why Wales were probably the first place to think about doing something a bit different with this. We have got a major problem with obesity in Wales, and that links with things like deprivation. It also links with heart disease and some of the cancers as well. So obesity is very, very high on our agenda. In fact, we've now got a maternity strategy that's just come out where public health is very, very high on it in Wales because of the issues that are around it. So the obesity trends, if you look at where, and we've only got England stats on this, but if you look at where England are going compared to the States, and we also always all know what's happening in the States, you can see that actually we're mirroring what's happening in the States. So our obesity epidemic is rising, and it's not stopping. And I've been a midwife for more years than I care to remember. But if I look at the women that are walking through our doors now compared to when I first started over 20 years ago, then I can see the difference myself. If you look at something like the CMACE report that reports on why women die in pregnancy, we've seen from that obesity is now a major part of that survey, whereas about 20 years ago that wasn't the case. This is why, as midwives, health visitors, school nurses, we should be really concerned about what's going on with children at the moment. Because if you look at the obesity levels here, and Wales, unfortunately, is third on this list, and England, Scotland and Ireland are about halfway down. This shows the obesity level in children that are 15, and this was in 2005 to 2006. So these children are now becoming childbearing adults. And if they're obese at this level, then actually by the time they come into pregnancy, they're positively going to be obese, most probably. Okay? That means that our maternity services are going to drastically change, because if you've got a majority of obese women coming in pregnancy, we are not going to need midwifery-led units, we're not going to need home births, all we're going to need are consultant-led units with high rates of caesarean sections and high rates of inductions. So we're going to be going to where America are now. So that's why we need to do something now. Unfortunately, even though what I'm going to now tell you about what we're doing in pregnancy is useful, I'm sure Tam mentioned it this morning, We have already closed the door after the horse has bolted, because we don't want these women when they're pregnant. We want them when they're 15. And that's when we need to be sorting it out. Because if we don't start looking at women that are starting to come into childbearing, so starting to go to GPs to ask for the pill, starting to go to family planning clinics, if we don't do something then and refer them on for weight management, then actually when they walk through our doors, it's a bit too late, because you can't do anything major in pregnancy. Okay, the Foresight report is a report that came out in 2007 by the Department of Health, and what it did was it sort of forecast basically where we're likely to be with obesity. And it said by 2050 that 60% of men and 50% of women were going to be obese. So that's 50% of the women that are walking through our doors are going to be obese. And it also suggested that we need a multifaceted approach to actually sort out obesity. And that means that we need to target it from lots of different angles. And that may be targeting it in schools, it may be targeting it in pregnancy, in family planning clinics, in lots of different ways. So whether you're a health visitor working with families talking about diet, or whether you're a GP who's got someone walking in who's perhaps the age of 20, she's come for her pill, you've noticed that she probably has got a BMI that's fairly high, why don't you put her on the scales? Why don't you measure her BMI and do something at that point? So, why have we got a growing epidemic? Again, I'm sure you did a little bit of this morning. This is around lifestyle. We know that we're becoming more sedentary. Yes, people do go to the gym, but they're not walking and doing as much activity as they were doing before. Convenience foods. We know convenience foods, even though some of the labelling has got better, it's still got lots of hidden sugars, it's got lots of hidden fats. Everybody goes for the low-fat things, but actually they're still not that low in fat. We've got reduced exercise, knowledge. What's taught in schools nowadays about a healthy diet? And from working on the HELP study and going out and seeing women that are obese, it's really interesting to find out what they know about a healthy diet during pregnancy. And they don't know that much. But also I would ask the students, what are you actually taught in your courses as well? How much do you do on a healthy diet in pregnancy? Do you feel confident in talking about diet and exercise? Do you know the research that's behind it? But also, are you happy to raise the subject about obesity in pregnancy? Do you feel confident to do that when a woman walks into a room? And the genetics around that, and there's quite a lot on genetics. There's some studies going on around placentas and the links to obesity. So there's some things that are coming out. Okay, so is it an issue in pregnancy? Yes. We know that 1 in 5 in one of the research studies in 2005 showed that women were obese, but actually CMACE did a study about 2 years ago, and they showed that probably 1 in 4 women were obese during pregnancy. We know it's linked to generally poorer health, and I'll show you some of those bits now. But we also know that women that retain their weight gain after pregnancy can lead to long-term obesity. If they don't lose it by 6 months postnatally, they're very likely to lose it. And one of the major concerns that I've got is the celebrities that put on a lot of weight, get a personal trainer and then lose it quickly afterwards. Because all that's saying to women is fine to gain weight in pregnancy because actually you can show how much weight you can lose afterwards. That's not what we want. We don't want women gaining weight in pregnancy. We want the eating to go completely. We also know that excess maternal weight gain during pregnancy is linked with obesity in children at 3 years and then into adolescence as well. So women eating a lot during pregnancy is really not on. And I think sometimes talking to some of the women, they say, well, actually, I've always worried about my weight, but when I'm pregnant, my body shape's changed anyway, so it doesn't matter what I eat. But actually it does. We need to tell them what's going on by them doing that. So what are the health implications for mum? Well, if you go to any medical clinic where there's a load of pregnant women, you will see women who've got high blood pressure. You will see women that get gestational diabetes. Now, again, when I first started as a midwife, gestational diabetes was quite a rare thing. But actually, how many women come through our doors now and have glucose tolerance tests? How much money are we spending on glucose tolerance tests? How many women are then ending up on diet-controlled with diet-controlled diabetes or even on insulin. And actually, we've made pregnancy abnormal just by having obesity as one of the factors. Also, increased emergency and elective section rates. Elective section rates, I think, is quite an interesting scenario because I think sometimes we get very concerned about the size of mum, the size of baby, and then we start talking about whether that woman should have an elective section. Also, if you've got gestational diabetes behind it and you've got high blood pressure, then that's another reason that you might go for an elective section. But if you also look at statistics in maternity units, the caesarean section rate doubles every time your BMI goes up. So when we looked in Cardiff at our caesarean section rate, once we looked at women with a BMI of 40 or more, 50% of those women had a caesarean section, which is scary, because that means that most probably they're going to end up with a caesarean section next time. Increased induction of labour rates. We know from the research that women that are obese are less likely to go into spontaneous labour. Now, the reasoning behind this is that the muscles of the uterus have actually got fat layers in between them. So the woman is less likely to have contractions that are good if she does go into labour. So she's more likely to need speeding up. She's more likely to end up with a caesarean. But she's also less likely to go into spontaneous labour. Venous thromboembolism, which was one of the biggest killers in the last CMACE report that looked at mums that died in the UK, is a huge issue with obesity. And actually, if you look at some of the thromboembolic guidelines that are around, it says that we should be going out and giving women injections to stop them having blood clots in pregnancy, and going out and seeing them antenatally, which it just feels so abnormal, doesn't it, when pregnancy is a normal thing. And the increase in postpartum hemorrhage. And again, unfortunately, I've seen quite a lot of women go to intensive care units that have lost massive amounts of blood. And this is, again, because of that fat that's in between the muscles of the uterus. So once the placentas come out, usually the uterus, the muscles clamp down to stop bleeding. But actually, if you're obese, that can't happen. So for baby, what are the implications? We know that the chances are that a baby may have problems coming out with shoulder dystocia. So for anybody in the room that isn't a midwife or doesn't know what shoulder dystocia is, that's basically that the head comes out and then the shoulders get stuck. To actually deliver a baby in that position, sometimes you've even got to get to the point that you've got to break the clavicles to actually get that baby out. So it's quite traumatic both for mum and baby, and it can also result in fetal death as well. The reasonings behind that is you could have a big baby, and that could be one of the reasons, but also you've got to remember that a woman's not only got fat deposits on the outside, but also on the inside, so your outlet is reduced as well. There's also, from the research, the likelihood of preterm birth, admission to neonatal units, which when you look at all of the maternal factors that are going on, quite often that baby is going to be at a lower health risk. You've got things like birth defects, spina bifida, and one of the reasons that the NICE guidelines had actually come out with the fact that women should have more folic acid when they're pregnant is because they don't actually absorb as much folic acid, so there's more risk of spina bifida. The risks of stillbirth, and I think for any midwife, she's probably come across a lady who is obese that comes in pregnancy saying she can't feel the baby move. And this is usually just because of the fact that there's so many fat deposits. She just doesn't feel the baby move. And so that early detector that says that a baby's not feeling well because it's not moving around as much actually goes because the woman gets used to that baby not moving. And so when she does come in, and unfortunately on a pilot we did have one lady who did have a stillbirth, and she was that scenario in the fact she hadn't felt the baby move, but she'd been in a few times before and felt she was wasting people's time, so just didn't bother coming in the last time, and that baby had died already. And macrosomia, which is related to diabetes, and it's when babies get basically fat, but their bodies can't cope with it, so their organs can't cope with the size of their body. Right, morbidity. Unfortunately, 50% of the women that died in the last triennial CMACE report, so the women that died in the UK in in 2008, looking back for the last 3 years, were obese. And one of the statements that CMA says at the beginning is, the death of a mother, a young woman who had hopes and dreams for a happy future, but who dies before her time, is one of the cruelest events imaginable. The short and long-term impact of such a tragedy on her surviving children, partner, wider family, the community, and the health workers who cared for her cannot be overestimated. And I think any midwife that looks after a family where a mum has died knows exactly what that impact is. Obesity is one of the biggest things that we can stop happening so that women don't die. And so we need to do something about it. So the last triennial report, as I said that about 50% of the women were overweight or obese, and 260 women died in the UK directly or indirectly related to pregnancy. Now, we have got a good maternal mortality rate in the UK, but unfortunately, the direct causes of death are going down, but the indirect causes, such as obesity, are the ones that are going up. So are we prepared for obesity, and at what cost? Again, if you work within the NHS, I'm sure you've seen some of the issues that are coming out already. The care costs are definitely higher. Things like glucose tolerance tests, things like having specialist scan machines because you can't identify the fetus because of the layers of fat. Having scanners that scan people that actually do the scans and then have a break in between because of repetitive strain injury, because of actually trying to get in to see what's happening with the baby. We also know that women with a BMI of 29 and over have an increased stay in hospital, again related to things like caesarean sections, diabetes. We know that babies go to the neonatal unit far more. And the need for specialist equipment. Who's had to look for a specialist bed, a specialist wheelchair, a specialist operating table? At the weekend, trying to get all your bariatric equipment, it's a nightmare, isn't it? We don't have planned admissions, so we actually have to go around and find them, or we have to make sure they're on our units anyway. So what happened in Cardiff? What changed for us was the introduction of 2 midwifery-led units. And at that point, I think we then realised that with the risk assessment we had for women to either have a midwifery-led unit birth or a home birth or a consultant-led birth, it meant that women all of a sudden were being told, well, actually, you can't deliver in the midwifery-led unit with the pools and everything else because you're obese. Now, one, we don't say it quite that way. But it's really difficult. We've just recently done an audit, and what we found was that quite often the reason given for the woman giving birth somewhere else was we'd found another reason apart from the obesity. We hadn't actually said to the woman, that is the issue. You are slightly overweight in your pregnancy, your BMI is high, and so because of that, these are the risks in pregnancy, and this is the reason you can't give birth in this particular place. We also noticed a rise in the caesarean section rate, and when we looked at that related to obesity, we realised that there was a link, and so we decided we wanted to do something with it. So what we did was we initially went to our dietetic service to ask them if they could help us. We had no money, and nobody's got any money, have they? So everything had to be cost neutral. I love that word. So the dietitians said basically they didn't have time to give to us that they could do anything extra with us in our service. So we decided to think outside the box somewhat and decided that pregnant women do go to places like Slimming World. Now, they're not allowed to go to Weight Watchers, which is why we didn't pick Weight Watchers. But Slimming World was something that we thought, well, actually, let's have a look at the plan in Slimming World and what happens. And when we looked at the plan that Slimming World follow, it's actually very, very close to what we ask women to do in pregnancy anyway. And we thought, well, they've got the tools, they've got everything that we need, and let's see if they will join with us for nothing. So we rang the head office and said, we're interested in joining with you. Would you do a pilot just to see whether a support group for pregnant women would help these women to stop gaining so much weight during pregnancy? And luckily, they were just starting to branch out into the NHS and said, yeah, okay, then we'll go for that. So we actually got 2 years of free groups out of them, which was very nice. But we made sure that we researched it all so that we were a pilot then, so we could look to a larger randomised controlled trial. Anybody who works in research knows a randomised controlled trial is like your perfect answer. So that's what we were heading for. Okay. So this was our stats in Cardiff up to 2008. So you can see why obesity was an issue. So in 1990, when I was a midwife, 3.2% of our women were obese. And by 2008, a quarter of them were. And I would say probably now about 30% are. So I've been through that. That's actually one of our babies from the group. So the feasibility study was looking at the acceptability of a healthy eating group for pregnant women with raised BMIs. So we weren't necessarily looking at the outcomes. We were looking at, was this acceptable to women? If you offered it, would they come along? Did they like it? So we had funding, a small pot of funding from Cardiff as a research grant, and that was enough to give us a research midwife to run the groups and to get some data out of it. And we started recruiting in 2008. The main goals were to promote a healthy diet and lifestyle in pregnancy. So that was talking about both foods and exercise in pregnancy. To provide support and advice on a weekly basis from both a Slimming World consultant and a midwife. And that was the important bit, because yes, they can go to community groups, but they're with non-pregnant women at that point, and we wanted it completely pregnancy focused. And to enable weight management during pregnancy by weekly weighing. So that's gone completely from where we were before, because if you think we've stopped weighing completely, and we're just bringing weighing back in because of CMAs. That music's very off-putting, isn't it? I feel like I'm being serenaded.
I think it's surely possible.
So weekly weighing, which does feel completely different, and to offer peer support within the group. So we had quite a few different bits going on with it. Okay, so one of the questions that everybody asks is, how much weight should women gain during their pregnancy? The only thing that is out there, and I was hoping that the nice guidance that came out was going to answer some of this, but unfortunately it didn't, is the only guidance we've got is the IOM guidance, which are American guidance on weight gain during pregnancy. So that is what we've sort of gone on. And basically, if you're obese, then you can only gain 0.5, 11 to 20 pounds during pregnancy. So you can't gain a huge amount during pregnancy. Okay, so how the group worked, we invited women from the beginning of their pregnancy, so at booking, at around 12 weeks, if they had a BMI of 30 or over. Now, the reasons why we went to 30 and not 35, we did start at 35 and then really started getting worried about the ladies in the 30 to 35 group. Because if you've ever worked on a midwifery-led unit, especially now we don't weigh women, if you've got a woman who's got a BMI of 34 at the beginning of her pregnancy, who then decides to put on 4 stone during pregnancy, you don't want to be that midwife on duty when she walks into a midwife-led unit, especially if you're not even alongside and you're 15, 20 miles away from your local unit. Because the chances are that woman's got a lot of risk then involved in that pregnancy. So we decided that 30 to 35, we wanted to bring them in as well, because we wanted to stop those women gaining excess weight, because actually they were the ones that we could keep in the midwifery-led units. They could have the birth they wanted, so they had even more to go for. It was free attendance, so it was on a referral scheme basis. And the sessions, as I said, were run by a midwife and a Slimming World consultant. And we did weekly weigh-ins. If anybody's ever been to a Slimming World group, sort of a bit like a Slimming World group, I wasn't like Marjorie from, what's it called? Can't think of the name of the programme, but I wasn't like that. Little Britain, isn't it? I wasn't like Marjorie. So we would do weight. We'd also talk about pregnancy, and we'd talk about diet and lifestyle during pregnancy. That was quite interesting because actually, I don't know what it's like in all of your areas, but antenatal classes are something that really women don't go to on their own, especially during the whole extent of their pregnancy. So they liked that as well. They loved having their own midwife. If you had any problems, every week you saw your midwife, great. And they also liked the fact that they had lots of other pregnant women with them. So it was a bit of a sort of chatty group as well. Okay, so the total number agreeing to take part in the study for this little period of time, this is the only data that we've actually assessed at the moment, was 67. But not all of those were going to come to the group anyway. So a few of them we sort of used as a sort of semi-control, but they weren't really. But the total number attending the group were 21. This was the group, varying sizes. It was quite interesting, the media interest in this, because the media, when they actually came to the group, got very disappointed at the fact that the women weren't sort of oversized women. I think they expected them to be, you know, the ones that couldn't get through doorways and things, but these are normal women. And I think that reminds us as healthcare professionals that actually we need to think about BMIs, even if a woman looks completely normal, because I think we've normalised, especially in that 30 to 35, we've normalised those women and we think those are average-sized women, and usually their BMIs are quite high. So the results, who attended, mean age was 30, but they ranged. Our mean booking weight, so they ranged from 12 stone 8 to 22 stone. So their BMI was from 32 to 49. It was interesting, we didn't get any of the over 50s. We have got women that have got BMIs of over 50, but they didn't tend to come to the group. And you could argue, was that something about body image, about them coming along? I'm not sure. Who referred them? It was very interesting to start off with because the clinic midwives were the ones that tended to refer them, mainly because the clinic midwives were running the group. But the obstetricians have been the ones since we've actually finished the group, because unfortunately in the randomised control trial, Cardiff came out as one of the control sites. So we had to stop our group when the big randomised trial started. The obstetricians were the ones that were the most up in arms because they loved the group and they can't wait for it to come back again. So it's definitely going to come back in Cardiff, whatever. And Slimming World did refer some of their ladies that were pregnant as well, and still do. Was it their first pregnancy? No. And actually the multips were quite interesting. So the ones that had babies before were desperate to come along because they said, I put on 4 or 5 stone in my last pregnancy and I haven't lost it and I can't possibly go there again. And that's why they came back. How many times did they attend the group? And this was the most interesting bit. Once we got them through the doors, actually 67% attended 7 or more sessions. And you can see that some women came all the time. 28 sessions one woman had. So some of them did attend a lot and they even wanted it over Christmas and everything. It just became their weekly thing they liked doing. The women that come once or twice, some of them is not for them. And I'm not saying this is for everybody, because I think some of the things that we need to do need to be on an individual basis, because not everybody likes groups. Not everybody feels that confident with their own body image. Their weight change at 36 weeks. So if you look at the ones that came to the group, our lowest gain was a lady that lost 2 stone. Now, when I spoke to the Royal College of Obstetricians, there was a sort of gasp in the audience that anybody in pregnancy loses 2 stone. But this lady actually had a really unhealthy diet in her pregnancy. So she was drinking full sugar Coke, she was eating chips and takeaways, she was eating crisps. Every day that she worked at the end of a street in Cardiff called Caroline Street. If anybody's ever come to the rugby, it's our Chippy Lane. And she worked at the end of that, and every day used to go and have chips and pie and mushy peas or whatever. But when she came to the group, what she then did was she used to walk past all of the chip shops, the jacket potato place at the end, have 2 jacket potatoes, beans and cheese. And all of her workmates said, you'll never lose weight like that. But actually she did. What was important about that woman's weight loss is, yes, nice to say that women should not lose weight during their pregnancy. But what is important is that you've got a health professional watching what that woman's eating and knowing that she's doing a food diary, knowing that she's eating the right foods, and there's been that dramatic change. Because if you look at what the baby would have had on her old diet and what the baby had on her new diet, then actually the baby was far healthier with the one that made her lose 2 stone. So it's thinking about it logically. The highest weight gain we had was a lady who put on 2 stone. Now, when you think that some women can put on up to 5 stone, 2 stone's not too bad. And our mean weight gain was 8 pounds in the whole of a woman's pregnancy. One of the little snippets I'll give you from the randomised study is that the women coming to group at the moment, most of them, by the time they come back postnatally, have lost more weight than when they first started. So most of them are 2 or 3 pounds lighter than when they first started. Some of them are even more than that. Okay, so it's sort of, we're starting to see it playing out in our stats as well. The non-group we sort of looked at, but unfortunately some lovely person threw away the book in one of the clinics where we were weighing the women, so a load of my data went. But you can see that a lot of those women put on a lot more. So what the women thought, the women in the study were amazing because they actually became converts to the whole idea. And by the end of the study, we actually had a sort of end of pilot farewell, and we invited all the women back, and all the obstetricians, midwives, and anybody else who wanted to come, had a bit of a party, but also asked the women if they'd like to stand up and say something about the study and what it had done for them. We had one lady who, when she came into her first group, had her coat on, left it on for the whole time, absolutely no eye contact, didn't speak to anybody, but still came back the next week and came back the week after that, started getting a little more confident. By the end, she was the one who stood up and spoke to everybody and talked about how it had changed the way she thought about herself and the way she thought about her whole family and their eating. So it didn't just change the way she ate, but it changed her whole body image and how she felt about herself during pregnancy. Okay, so the HELP study itself is a cluster randomised control trial. A cluster randomised trial is basically I'm doing all right for time, is basically maternity units. The reasons why we didn't do an individual randomised trial was that we didn't want women talking to other women about what they were doing on the Slimming World. And pregnant women do tend to know one another. So we said if we had a load of women from one maternity unit, the chances are you were going to get some sort of mixing of information. So that's why we decided to do just maternity sites. So we've got 20 sites across the UK. We've got a couple in London. We've got quite a few up north. We've got Kent to the east. We've got 4 in Wales, and then we've got some down south. So I seem to spend a lot of time travelling at the moment. And the idea of the study is that we're doing the intervention in half of those sites. So half for intervention, half for control. The intervention sites are offering it to the women from 12 weeks in pregnancy. And we can offer it they can start up to 20 weeks as well. So 12 to 20 weeks is our referral criteria. And then they have it for the whole of their pregnancy and for 6 weeks after. The reason we stopped it at 6 weeks is that it can sometimes turn into a bit of a mother and baby group, and we wanted it to be pregnancy focused, and that's why we stopped it then. But we're reviewing them up to a year, and the reasons that we've done that is we wanted to see that it had a long-term effect, because it's all very well and good doing it for pregnancy and looking at pregnancy outcomes, but that's not going to gain long-term funding. We want to show that this is something that's going to change their lifestyle completely and for the family. So we got funding from the MPRI. We've got 4 years duration, and I think we're nearly at the end of year 2 now. And, right, the purpose of it is basically to see whether the intervention does lead to lower weight gain during pregnancy, but also if it leads to fewer complications. And we're just having our births coming through now, and that data has been quite interesting so far. But also what the impact is on physical activity, mental health, self-efficacy, social support, and child's weight gain. What's been really good about it for me is the fact that our PI is actually somebody who is a health economist. No, she's not a health economist. She's a health, I can't even think of the word. But basically, a health psychologist, that's what she is.
Not quite the same.
Not quite the same, no. We have got a health economist who is absolutely brilliant, and hopefully he's going to give us the data for the many bits. But the health psychologist has been brilliant in the fact that when I did the groups, I had this feeling, like I was talking about that lady with the coat, that this actually wasn't just about what women were eating. This was something completely different about how they felt about themselves, how they felt about pregnancy. There's also quite a lot of data to show that things like perinatal mental health issues are one of the issues that come out of obesity as well. So we wanted to see what are the effects on these women long term on the whole of their health and their families. Okay, so the primary outcome point is 12 months from birth. And we did have lots of discussions around whether we did this or not. But as I said, we thought that 12 months after would give us a good idea if these women have rebounded weight-wise. Have they gone back to their old lifestyles? Because pregnancy is one of those times that you do change things. If you think about smoking, how many people give up smoking when they're pregnant? As soon as the baby's born, they start again because they think, oh, I've been healthy when I'm pregnant, I'm going to start again. But we want to show that this is something that actually, because of that weekly input, these women have got into the habit now of eating healthily and exercising. The exercise component of our study is actually giving women pedometers, and what we're trying to do is increase their walking. So they're not doing aerobics activity or anything else. We're literally trying to get them to think about increasing their walking. Okay, so I've explained that it's a prospective cluster randomised controlled trial. We have nearly finished recruitment. We were supposed to have finished recruitment in February, and we did have to have an extension. We need 560 women, and we have 520, so we're nearly there. So hopefully it won't be long. Okay, so it's 20 maternity units across the UK, and they're recruiting 29 women each. And you would think that 29 women is quite easy. It's been really difficult. And I think the reason it's been really difficult is going back to, are we brave enough to ask the question to start off with? And one of the pieces of research that's probably going to come out of this study is around asking the question, because I think we've learned quite a lot about it. The women are going to be between 12 and 20 weeks pregnant, and we've included both first-time mums and multips. So they're recruited between 12 and 20 weeks. If they're in the intervention group, then they come along they're invited to the groups free of charge every week until 6 weeks postnatally. We're following them up at 36 weeks, at 6 weeks postnatal, 6 months and a year. And all of those we're doing as home visits, because what we wanted to do to try and make it as easy for the women as we possibly could. We aren't using anything like blood test results or any of those bits. We felt that that was something that was a completely different study, and that actually we wanted to look at the social support elements, the psychological issues, all of those bits. Okay, and I think I've done fairly well. That is it. All right.